morning, ladies and gentlemen. Truly, this is a three-dimensional conference. I was delighted to see the previous speaker talking on thyroid and how beautifully he weaved the thyroid gland before the pancreas. I must thank Dr. GVK for arranging the 3D approach. But I'm going to put my talk before his because I am 3C. He may be 3D in the conference, but I'm going to talk on 3C diabetes. So 3C diabetes is a secondary diabetes, a pancreatic origin where the pancreatic diseases with exocrine deficiencies leads to endocrine dysfunction, resulting in defective glucose homeostasis. And the march of events leading to a recognition of pancreatic diabetes as a separate entity started with the observation of diabetes occurring in the young population, especially in the tropics, where chronic pancreatitis was found to be the main reason. They initially called it fibrocalculi pancreatic diabetes, but after years of dilly-dallying, where they called it tropical diabetes, malnutritional related diabetes, it has finally been proven that this entity is a separate one. Later, other pancreatic diseases due to other causes like carcinoma, pancreatectomy were also given separate recognition by ADA and WHO, which we now call diabetes 3C. So what is the cause and effect phenomena of diabetes 3C? You know, nomenclatures enlarge every day with more and more research. We know type 1, we know type 2, and now we have gone up to type 4, with 3 being broken up into different alphabets. I'm going to stick to 3C, where diseases of and trauma to the pancreas, whether it's pancreatitis, malignancy, hemochromatosis, cystic fibrosis, or even pancreatectomy. And the subclassification of causes of type C3 diabetes, according to their potential mechanisms, is congenital or acquired complete absence of the islets. You can have pancreatic agenesis, or you can have acquired where there is pancreatectomy total. The acquired partial absence of functional islets is quite often, as we see it in chronic pancreatitis, partial pancreatectomy, severe acute pancreatitis, cystic fibrosis, and hemochromatosis. I don't know how many of you have seen hemochromatosis, but I've seen 3 to 4 cases, and especially in 2 families, and you do get a significant amount of disrupted glucose metabolism. Then of course there is the paraneoplastic, where you get pancreatic ductal adenocarcinoma. And of course the transient hyperglycemia of acute pancreatitis. I'm sure in your indoor practice you may have been called into ICU by the reluctant surgeon to treat the surging sugars. So the epidemiology, if you see in the general population, the prevalence, as we know, of type 2 diabetes worldwide is about 8%. In India, it is close to 20%. But as awareness regarding type 3C diabetes becomes more and more as a separate clinical entity, in the Western data, there is almost a 10% incidence. Though concrete data is not available in Asia, as more and more awareness spreads, I'm sure we'll get similar values. And look at these 2 pie diagrams. The prevalence of 3C diabetes in about 1900 participants, where you can see type 2 is about 68%, type 1 is 23%, and 3C is as much as 9%. And if you see in the causes, you can see 79% is because of chronic pancreatitis. And we all treat patients of chronic pancreatitis, and it's like treating fatty liver. We have no really treatment. What will precipitate the next attack of pancreatitis, especially if he's given up his alcohol and other things? You can never tell. Suddenly the patient says, sir, I was fine for the last 10 months and suddenly my amylase lipase has gone up. So that is the chronic pancreatitis story. Like you and I have no answers in the medical health checkup. When the patient comes, sir, sab report bolta hai normal hai, but you have fatty liver. What is the treatment of fatty liver? So chronic pancreatitis is the main cause for 3C. In the pathogenesis, how does this diabetes come about? The tissue injury is thought to occur due to premature activation of pancreatic enzymes. And this causes inflammation and auto-digestion of pancreatic tissue, leading to tissue loss. There is replacement fibrosis, septa formation, and calcification, which leads to exocrine deficiency, which then leads to endocrine loss. So exocrine deficiency predates endocrine deficiency, which finally leads to diabetes. The exocrine deficiency leads to nutrient malabsorption, resulting in impaired incretin secretion. We all know that the incretin effect is only following an oral load and not an intravenous load. So if you have nutrient malabsorption, you have impaired incretin secretion, thereby decreasing the stimulus for insulin secretion. Remember, pancreatitis is not selective for alpha cells and beta cells. Even the alpha cells get gobbled up. So glucagon also gets affected, though a little later in the course of the disease. And when you have both beta alpha involved, the response to hypoglycemia, you have wide excursions of glucose levels, making this diabetes quite brittle. The crux is the pancreatic diabetes, the tissue sensitivity to insulin is intact. There is no problem with tissues, there is no insulin resistance, there is no insulin antibody. So the tissue sensitivity is intact, which brings me to hepatic insulin resistance, which is multifactorial, with a deficient pancreatic polypeptide response, which plays a key part. And pancreatic polypeptide regulates the expression and availability of hepatic insulin receptors. And the diminished insulin receptor availability in chronic pancreatitis can be reversed by administering this pancreatic polypeptide. There are different markers and different autoantibodies which can also be used and blocked to improve hepatic sensitivity. So this reduced incretin effect is important. In type C, 3C diabetes, the sensitivity to GLP-1 seems to be intact, but the late phase insulin secretion, which is response to GIP, is reduced like it is reduced in type 2 diabetes. And as I said, due to the exocrine pancreatic insufficiency, impaired absorption, reduced incretin with reduced postprandial insulin secretion. However, if you give pancreatic enzyme replacement therapy, PERT, this will immediately result in increased postprandial responses to both GIP and GLP-1, because the main cause has been looked into. So it's a matter of balancing the sweetness, the exocrine with the endocrine. What are the clinical features? These patients usually have a history of pancreatitis in the past, with the classic pain in abdomen, dyspepsia, steatorrhea, and symptoms of malabsorption. Due to a defect in fat-soluble vitamins, which is A, D, E, and K, they may show features of these vitamin deficiency states. Initially, overt diabetes or hyperglycemia may not be present, but only occurs during periods of stress like illness, surgery, high-dose corticosteroids, because it's not frank overt hyperglycemia. But as the beta cell deficiency progresses, the pancreatic islets get eaten up, these patients develop overt diabetes. However, these do not develop diabetic ketoacidosis as often as you see it in other diabetic conditions. But brittle diabetes is known because alpha-beta balance is disrupted. When do you suspect it? The diagnosis of pancreatic diabetes is entertained When patients of diabetes mellitus have abdominal symptoms and features of malabsorption, wherever there is ambiguity regarding the typing of diabetes, is it type 1, is it type 2, possibility of pancreatic diabetes should be thought of. Conventionally, typing of diabetes is confirmed by presence of type 1, where you have associated autoantibodies, and type 2, where you have insulin resistance. In 3C, the diabetes investigations for exocrine and endocrine should be done. So it's a strange diabetes. You want to treat the diabetes, but you have to treat the pancreatitis. And that's the dilemma which should make you click that this is diabetes 3C. For exocrine deficiency in pancreatic diabetes, you do fecal elastase 1 estimation, which is a very non-invasive conventional method. You can also do a polypeptide response to 12 ounces of boost high protein, which is supplemented with pancreatic enzymes, and then you see what is the best value, where in a normal you will get a 4 to 6-fold increase, but in pancreatic diabetes it will be impaired. However, in today's age, all you need to do is an ultrasound. And if you get calcification in the pancreatic duct, the above test of fecal 1 elastase may be omitted. Of course, criteria are laid down. Ewald and Bretzel have laid down major criteria where you must look for the monoclonal fecal elastase 1. You can do pathological pancreatic imaging with ultrasound, MRIs or CTs, and you must document that the absence of type 1 diabetes autoantibodies are absent. There are a few minor criteria. Impaired beta cell function as measured by HOMA-BC peptide glucose ratio. No excessive insulin resistance as measured by HOMA-IR. Of course, impaired incretin or pancreatic polypeptide secretion, and low levels of vitamins. It's a brain teaser. What the mind knows, the eye sees. So if you think you don't know whether this is type 1, whether this is type 2, you're confused, you're getting erratic levels of sugar, and you're getting a history which is strange. Look at this graph. Maybe this graph will help you. The pancreatic diabetes, the insulin secretion is reduced, the insulin sensitivity is not affected, glucagon secretion is reduced, plasma amino acids increase. It is prone to ketosis, not so much as the others like type 1. You can see what happens in type 1 and type 2. What are the complications of this type of diabetes? It follows the same risk pattern as that of type 2 diabetes, with both micro and macrovascular complications. Both diabetes and chronic pancreatitis are risk factors for pancreatic ductal adenocarcinoma. You know, there was a lot of hue and cry a few years ago regarding certain drugs causing pancreatic malignancy. But then it was finally seen that it was the pancreatitis itself which was a marker for pancreatic ductal adenocarcinoma. Hence, type 3C diabetes can be considered as a pre-malignant condition. The management of this diabetes is the same as the rest. Treat to target less than 7 to minimize the risk of complications. Lifestyle modification, because that is the cause. The alcohol, the smoking, all have to be recommended to be stopped so that the underlying pancreatic inflammation and fibrosis go away. The treatment of pancreatic 3C diabetes is more difficult because the patient comes with pain, pain, and pain. And you have to give these pancreatic patients even narcotics to relieve the pain. As you and I know, the treatment of chronic pancreatitis is in as much treatment of what it should be replaced with exocrine, endocrine, it is the treatment of pain. You know that alcohol also inhibits hepatic glucose production and cause hypoglycemia, especially if you're giving these patients insulin. So alcohol should be abstained. Medical nutritional therapy, eating meals rich in soluble fiber and low in fat, with some degree of pancreatic exocrine insufficiencies with oral enzyme replacement. Pancreatic enzyme replacement therapy can be used for digestion and can improve the incretin effect. And of course, maintaining levels of vitamin D and others. So if you assist digestion, you can assist the incretin activity. What about controlling the sugar? Here, insulin therapy is preferred because the diabetes is brittle. And now with lot of major advances available, basal bolus insulin dosing regimes and regimens should be considered, especially in type 1, carbohydrate counting for flexible brandial coverage. You can also think of the pump for selective patients. What is the role of oral hypoglycemic agents? Metformin may reduce the risk of pancreatic cancer. So it does have a theoretical rationale in chronic pancreatitis. But most of them have GI adverse effects and weight loss, so you don't want to give it. Thiazolidinediones carry an increased risk of bone fracture in such patients. Bones, stones, groans, remember, so it's not suited. You have to think of balancing alpha and beta loss. So therapy, you might say, I'll give it with secretagogues. But these are long-acting and can cause profound. The short-acting ones can be preferred when meal ingestion is predictable. But when not predictable, you can't give the long-term ones. Incretin-based therapy is very interesting and very tempting. But you all remember the gray lining to incretin-based therapies, which is pancreatitis itself, so it should be avoided. There is a new kind of modality, total pancreatectomy, with Islet autotransplantation. And this is considered as a definitive treatment for recurrent acute or chronic pancreatitis, not for the diabetes, but for providing pain relief, so the narcotics can be given and can be done away with, and there is amelioration of the frequent hospitalizations for pain exacerbations. Remember, it is important to appreciate that that is the objective of autotransplantation. That it also will work in achieving good glycemic control is secondary. What is the future? The Consortium for the Study of Chronic Pancreatitis, Diabetes and Pancreatic Cancer was formed in 2015 to undertake a comprehensive study, and they are still to come out with the complex relationships between all this. But the key driving force behind this effort is that the increased risk of developing pancreatic ductal adenocarcinoma in those with chronic pancreatitis, particularly those with diabetes, and the increasing mortality rate of pancreatic ductal adenocarcinoma, which is rising. This is extremely important, and definitions from this group will help. In conclusion, remember, type 3C diabetes is a separate entity with diagnostic criteria and treatment modalities. 5 to 10% of the newly diagnosed diabetes are now type 3 diabetes. Chronic pancreatitis remains the major cause. Exocrine deficiency often predates it. Defective pancreatic polypeptide response is an early marker. Pancreatic diabetes is brittle, and they are considered as pre-malignant conditions for pancreatic carcinoma. This is a matter of fact where you have to treat the cause before treating the condition, before allowing the patient to feast on his next meal. And if you don't think and preserve the patient, he will perish in the pancreatitis. So I think this is very apt that in a 3D conference we talk about 3C diabetes. Thank you for your attention.